with both hips X-ray AP view. Okay, this is pelvis with both hips AP view. Okay, look at this. See what you see. This you see. This is a acetabulum. This is a femoral head. Right. This is the neck. This is lesser trochanter. This is a greater trochanter. Right. Okay, so anyway, I have started discussion, so I'll also help you in identifying. You have to identify which is the side by depending the label. This is the left side. So always remember the fracture neck femur is between these two from intertrochanter. It could be subcapital, it could be transcervical, it is basal. Basal. Subcapital is just below the head. Okay, we are not deviating. Right? See, this is the head. You can see the trabeculae here. Just to kind of a recollection for recollecting the last class. Quick. I want anybody to respond. Only then it makes interesting and you can remember easily.
Yes, sir.
Manjunath. Is it Manjunath?
Yes, sir.
Okay, good. So we had discussed about the trabecular pattern, isn't it? Look at this. These are the fine trabeculae you can see. Primary, compressile. Primary which starts with the head. Secondary starts with the trochanter. So both have compressile and tensile trabeculae, tensile group. Trochanter is secondary, compressile and tensile group. Will not go there. But still, I just wanted you to recollect. See, everything is fine till here. Look at this. Look at this, what has happened. Look at this head. Can you see the head? What has happened here? You can see a small lytic lesion, isn't it?
Yes, sir.
Look at this. This is absolutely normal. Okay. Now you can see this head. There is a lytic lesion. There is no proper trabeculae seen. Here the trabeculae are everything is normal. So this is a case of
Right fracture neck femur.
no. Yes, who was that? Right. Okay. Where is right? This is right, isn't it? Wait, let me adjust myself. This is right. Okay, can anybody show me any fracture here? Where is the fracture? There is no fracture here. There is no fracture here. Is there a fracture here? There is no fracture. Can anybody see any fracture here? There is no fracture. It is not a fracture. Only thing is head is abnormal here. The texture, the appearance of the head, femoral head is abnormal. Look at this. This is quite round, spherical, spread, very pristine head. Look at this head. There is a double shadow, the head inside head, and the trabecula is not seen very well. This is avascular necrosis of the femoral head. Okay, can you remember? Now there is no fracture here. There is no fracture anywhere here. Okay, that's why it is idiopathic. Idiopathic avascular necrosis, because we don't know if he had any trauma. We are not sure, but there is definitely no fracture seen. Okay, we'll go further. Before going to understand the avascular necrosis of femoral head, I want you to understand the very, very intricate and very typical blood supply of femoral head. Please remember, it is very simple. Don't go by the diagram. Okay, this is head. See, what is important is you see it is like a mountaineering. You want to climb a mountain, you look at the peak, you feel it is impossible, but you take step by step, you will be there at the summit within no time. Similarly, when you see such complex diagram, don't be disappointed that you are not able to understand. If you can map it or unravel it step by step. Look at this. This is a complex vascular blood supply of the femoral head. But let us go step by step. See, medial circumflex femoral artery, medial circumflex femoral artery, and this is the lateral circumflex femoral artery. Okay, so one thing is very sure, we want one, they always follow symmetry. There is a medial and there is a lateral femur. So it is circumflex, it is going around the neck, isn't it? Lateral circumflex and medial circumflex femoral artery. Lateral, again there is a ascending, there is a transverse, there is a descending. Don't go into this. Just remember lateral and medial circumflex vessels. So what it does, it forms the ring here. It forms the ring here. It forms the, this circumflex is what going around and comes here. It forms the ring. From here, inside the capsule, above the neck. So please remember, it is extraosseous, above the neck, on the surface of the neck. It gives multiple vessels, multiple blood vessels. So these are grouped into, these are grouped into anterior. Anterior is one which is anterior and posterior. Lateral, so it is lateral, medial, anterior, posterior. So don't bother about that. So it forms a ring here, subsynovial. Then again the ascending cervical vessels. These are also called as retinacular vessels. I understand it is little painful to listen, but you please listen carefully, you'll remember. These are ascending retinacular vessels. They again form a small ring here. Rings are, it is like a finger ring where multiple anastomosis. From here they enter into the head. So till here, till here, till here, it was on the surface of the neck. From here, it gets into the bone. It gets into the bone. So what is important is, please remember, these are ascending cervical or retinacular vessels. There can be anterior, posterior, lateral, medial. So what is important is, you have to remember lateral epiphyseal vessels. Lateral epiphyseal vessels. I told you, isn't it? Anterior, posterior, medial, lateral. So from here, because it is getting into the head, they are called as epiphyseal vessels. They are on the lateral side, hence they are lateral epiphyseal vessels. So till this you remember, then we'll come to the importance of this little later. So this is the blood supply of the femoral head in the normal thing. So what happens in a fractured neck femur? The marrow blood vessels are also disrupted. The marrow blood vessels are also disrupted, and the blood vessels on the surface of the neck of the surface of the neck are also disrupted. So the head will go for avascular necrosis, because it is what is remaining. The blood supply is only from the ligamentum teres. Ligamentum teres. It supplies only about the 7% of the head. So that is not sufficient. It is like a irrigation canal. The main lines are cut, the small irrigation is remaining. It is not sufficient for the blood supply of the femoral head. Okay, we'll go to the next slide. So what happens in avascular necrosis? You have to remember, I will go to this. It is an idiopathic avascular necrosis. We don't know the cause, but these blood vessels which are inside the neck, I mean inside the trabeculae of the neck, because of certain diseases like steroid overuse or caisson's disease, because of deposition of the fat, the blood vessels get compressed and there is a shortage of the blood supply. Again, there is a avascular necrosis. I'm just trying to explain in very brief the pathophysiology. If you can remember, it will be great. So again, this is one case of slipped capital femoral epiphysis. Understand? So what has happened? The capital epiphysis before the fusion into the metaphysis, it has slipped. So again, there is a disruption of the blood vessels. So what is the complication? Again, there is a avascular necrosis. What is the complication of fracture neck of femur? Again, it is most common is avascular necrosis. What is the problem in a Perthes disease? It is again avascular necrosis. But please remember, avascular necrosis in Perthes is in child between 4 to 8 years. 4 to 8 years. I will come to that little later. This is the importance of understanding the blood supply of the femoral head. Okay, so I wanted to just one last slide of the picture, then we'll go to the MCQs. So avascular necrosis of femoral head, that is in Perthes. Please remember, see, in the child before the appearance of a growth plate, there is no growth plate yet. Before 4 years, I mean, before 4 years, there is no growth plate. So blood vessel go from the shaft into the head straight away. That is till 4 years. So what happens after 4 years? That is, there is a capital grow, the epiphysis of the femoral head appear. So there cannot, because it is a cartilaginous, the blood vessel cannot get into the femoral head. So the blood supply has to come from the outside. This is important, is lateral epiphyseal arteries or vessels is important, because that's when the blood vessel coming from outside get into the epiphyseal vessels, there can be injury and hence Perthes. So that's why you please remember, Perthes is common between 4 to 8 years of the age. Okay, you should know this, then you will remember. Otherwise, if there is a question appearing what is the common age group for Perthes, you will not recollect this. If you remember the blood supply pattern, then you will never forget. We'll go to this. So Meyer muscle pedicle graft is used for, okay, Meyer muscle pedicle graft is used for fracture neck of the talus, non-union fracture neck of the femur, waist of the scaphoid, intertrochanter fracture. Anybody want to take a chance?
Option 4, intertrochanteric fracture femur.
Option 4, no. Anybody? Second chance? There's no negative mark anyway here.
Option 2, sir.
Yes. Option 2. See, Meyer muscle pedicle. Forget the name of the person. Pedicle graft. Meyer muscle pedicle. Pedicle is what? It will have a blood supply. Please remember this. Pedicle is what? There is a blood supply. So that muscle comes with a blood supply. So where you want to use, where there is a avascular necrosis. Okay, but if you know what is the muscle, quadratus femoris, quadratus femoris. Of course, it is difficult for you to remember. I'm not expecting you to remember, know this, but you will definitely after the class, you should be able to remember this. Okay, I don't expect you to answer at least now, but after the class, you should be able to understand. So the talus, the scaphoid, and these are one more important thing before you finish. See, Meyer muscle pedicle graft. There is a, I have a picture of that. I will show you later. So, but please remember the talus and the scaphoid after femoral head. After femoral head, the other fractures which cause avascular necrosis are talus and scaphoid. Again, you please remember, I will draw a diagram of the talus. If I'm good at that, let us see. See, this is the head, this is the body. So here again, the blood vessels enter like this. If there is a neck of the talus fractured, the body will go for, so please remember, proximal portion of the talus or the scaphoid will be deprived of the blood supply. That will go for avascular necrosis. Okay, coming to this question, Meyer muscle pedicle graft is used for a non-union neck of femur where you want to increase the vascularity. So what they do, they take the piece of the bone from the quadratus femoris is attached like this. You should know this. So they will take the piece of the bone with the muscle and fix it with the screw here. So what you got, for non-union you require vascularity. That's what you got. The vascularity is brought from the muscle and till the fracture, which will help the union. I have a diagram for this. Okay. So please remember, see, quadratus femoris is on the posterior aspect. There is a neck. So what happens? This is the muscle before removing. This is muscle is removed with a piece of the bone. And here, look at this. The bone is fixed to the across the fracture neck femur. This is, please remember, Meyer's muscle pedicle graft. Meyer's muscle pedicle graft. Okay, before we complete, one more thing you please remember, there are other places also. You can take from here, anterior superior leg spine. What is attached here? Can anybody tell me quickly? Anterior superior leg spine, what is the muscle attached?
Sartorius.
Very good, sartorius. So you can take the piece of anterior superior leg muscle, anterior superior leg spine, fix it here across the neck of the femur with the muscle. You are getting with the muscle. That is also one of the muscle pedicle graft. Similarly, there is a anterior portion of the iliac crest on the outer aspect. What is the muscle which is attached here? Iliotibial band. So that also you can take. So you want to take a muscle attached with the bone and fix it. So what are the other options is, one is okay, one is Meyer's muscle pedicle graft is quadratus femoris. Oh my god. So one option is, if you can remember the diagram, quadratus femoris. Second is sartorius. Third is tensor fascia lata. Okay, just remember the anatomy. You can take the adjacent muscle with the bone. This is one more diagram I wanted to show you. So what you do, other option of treating avascular necrosis is you drill a hole here. You drill a hole from the lateral side of the femoral cortex. You make it hollow. So you reduce the pressure inside, intraosseous pressure, but this will collapse. So to avoid that, you put a fibula. You harvest a fibula. You harvest a fibula with the blood supply, but you have to anastomosis with the circumflex femoral artery. So you take the fibula from the same side with the blood vessels. You cut the blood vessels, artery and vein, but you have to anastomose with the lateral circumflex femoral vessels. Okay, we'll go to some questions. A patient, patient who used to work out regularly at the gym gradually developed a pain in the hip, which is aggravated while squatting, means flexion. He gives history of regular steroid and creatine use because they are muscle building drugs, which is banned, which are not supposed to be used by gym goers, but because of the competition they use. So he is a gym goer, steroid abuse, there is a flattening of the femoral head, and there is a subchondral collapse seen on the X-ray. What is the diagnosis? Do you want anything else to be telling the diagnosis? You should be able to tell me.
Avians. First of
Very good. Very good. Huh? There is so many things, so much of information given here. See, steroid abuse, flattening of the femoral head, hip movements are painful, subchondral cysts are there. You don't require anything else. It is nothing but avian. Fracture neck femur, no. Tuberculosis, osteomalacia, they are all just distractors. Okay. Most common cause of idiopathic, I'm sorry, most common cause of avian is, I told you the answer. Anybody?
Idiopathic.
Yeah. Okay. So most common cause of avascular necrosis is idiopathic. We don't know the cause. Of course, the others are also the cause of avian, but it is not the most common cause. All are true about avascular necrosis of femoral.
what about alcoholism?
Yes.
Sir, about alcoholism, how it causes avians?
What causes alcoholism? Causes alcohol, fatty liver. There is excessive fat deposition in the marrow, bone marrow of the femoral head, which increases the intraosseous pressure. Hence, it causes the avascular necrosis of the femoral head. Am I clear?
Yes, sir.
Okay, good. Anything else in this? Rest are all known. Caisson's disease is what? Decompression sickness, isn't it? You know what is Caisson's disease?
Yes,
Yes,
sir.
sir.
Scuba diving.
Scuba dive. Okay, good, very good. Have you done scuba diving? Anybody has done scuba diving?
No, sir.
You should do. You should do. There are so I have done a couple of times. Okay, anyway, will not go into personal things. So all are true about avascular necrosis of the femur, except, okay,
Option 5, sir. MRI is the investigation of choice.
okay. Did you read the question? Affected hip is kept non-weight bearing is correct?
Yes,
Yes,
sir.
it is correct.
Yes, sir.
Okay. Asymptomatic cases can happen. There can be pain free. Initial period is free.
Yes, sir.
Radionuclide scan shows increased uptake around the infarct. Is it correct? There is a cold spot around the necrosis spot, but surrounding definitely there is an increased uptake. No doubt about that. Isn't it? Trendelenburg sign is negative.
So it's positive.
Now you are stuck between these two. MRI is investigation of choice. Anyone wants to refuse this? What is the investigation of choice?
X-rays.
X-ray is very, very late. X-ray is very, very late. You will see that's why you have to take an MRI, even though if you see, I showed an X-ray in the beginning. On the right side there was avian, isn't it? But still you have to do MRI both hips, because you will see before X-ray picks up anything, there can be changes. There is a T1 altered signal. Trendelenburg sign is positive. Because of the pain, there is inhibition of, I will explain Trendelenburg sign in some other class. But please remember, Trendelenburg sign is because of the disturbance of the fulcrum. I will draw. This is the power, the abductors. Okay, this is the power. Power means abductor. This is a lever arm. The neck is the lever arm. And the head is the fulcrum. So what happens is, so what you should understand is, I'm losing the marker again and again. If you see a seesaw here like that, this is the fulcrum, this is the lever arm. If somebody sitting on this is a power or weight. So if there is any disturbance here, if there is any disturbances in the fracture neck femur, avian, or there is a coxa, there is a Trendelenburg test positive. Avian of the femoral, avian of the hip may occur following which of the fractures? Very easy question, read carefully. Interesting question, very likely to be repeated. Tricky question. Which
Option 3.
Yes,
Third option, sir.
third.
Third option.
Very
Neck
good.
of
No doubt about that. See, intertrochanter fracture, even though it is near the neck, it doesn't cause. Subtrochanter, definitely no. Acetabulum is far away. Only the answer is fracture neck of the femur. Avian of the femoral head, secondary to transcervical neck of femur fracture, occurs due to the damage of which of the following vessels? If you can recollect the diagram what I had shown before.
Option 1.
Very good, very good. Lateral reticular branch of lateral circumflex artery. Excellent. I will not definitely take credit for this. Maybe you remembered even before I explained. Good. Osteonecrosis is seen in all except. Yes. We have dealt.
Option 2.
Don't be in a hurry. Don't be in a hurry. You are not here to reach first, but you should reach in time. Okay. Anybody you want to rectify? Just go read again. Don't be in a hurry to answer. Come on.
Paget's, sir.
Very good, very good. See, it is Paget's disease. You know, last class I had explained, I'm not sure if you can remember, in Paget's, there is a disruption of osteoclast function, or there is increased, so there is, in the Paget's what happens, osteoclastic function is deranged. The osteoclast is deranged means abnormal bone laying down happens. soft bones happen and they are deformed bones. Okay. Now going here, you please read carefully the choices here. Fracture neck of femur, any doubt? Definitely not. It is avascular necrosis of femoral capital epiphysis. So I told you 4 to 8 years. Again, there is a vascularity problem, no doubt. Sickle cell disease is definitely because of the thrombosis of the vessels. It causes avascular necrosis. Now, either you do it by ruling out or you understand the pathophysiology. Then you will never miss your shot. Avascular, am I clear, Manjunath? It was Manjunath, isn't it?
Yes, sir.
Am I clear? You told Partis, isn't it?
Okay.
Shall we go ahead? Avascular necrosis of the head, which part is affected most commonly? Very easy. Read carefully.
So
Yeah.
option 2, sir.
Very good. Excellent. Excellent. See, that's why I was trying to give you a hint. This is an AP X-ray. This is a lateral X-ray. So it is here you see in the commonly seen weight bearing portion anterior. You see here anterior you can see on the lateral X-ray because in lateral you can see anterior and posterior. In AP X-ray you can see medial, lateral and medial. So no doubt about that. You remember it is anterolateral weight bearing portion of the femoral head which is early and which goes for avascular necrosis. Excellent. Avascular necrosis of femoral head is most common in. Go carefully. You will definitely answer. I think all of you can answer this. Read this.
Transcervical.
Which one?
Option 2.
Option 2. Anybody?
Option 1, subcapital.
Option 1. Anybody wants to again take a chance? Anybody? Okay. Option 1 is the correct answer. I'll tell you again. Please never ever you forget this diagram. See, I told you this is a basal fracture. This is a transcervical fracture. This is a subcapital fracture. And this is your intertrochanteric fracture. Okay? Are you following me? So as you go on, fracture goes on close to the head, the chances of AVN is very, very high. Very high. So transcervical, basal is less common, transcervical is next, subcapital is highest. Invariably, all these fractures cause AVN. But subcapital almost causes 100% of the times AVN. See, there is a chance that it will unite. But in subcapital, the chances of AVN is very, very high. As the fracture goes on towards the head, the chance of AVN is very high. You can remember this easily. There's no brainer. Patient who is using oral steroids for a period of 5 years, complaints of pain in both hip. Which is the best diagnostic tool There was some confusion in answering previous question.
MRI.
MRI.
Yes, MRI. You know why? See, you can always get stuck with isotope, bone scan, and MRI. Definitely CT scan, no. One thing you remember, CT scan is good for bone. MRI is good for soft tissue and bone marrow. Please remember. Okay, always remember. If you remember this basic thing, you will never forget. CT scan is for bones, MRI is for soft tissue, like soft tissue sarcoma, periosteum. You want to see the muscles, you want to see the bone marrow, extent of malignancy inside the bone, you want to do an MRI. So where you can get stuck, definitely X-ray I told you is very late. So now you can get stuck with isotope, bone scan, and MRI. But please remember, MRI gives exact site of AVN. Problem with bone scan, it is a two-dimensional picture. You will see just a hot spot here in the femoral head, but you cannot say whether it is anterior, posterior, superior, inferior. But in MRI, you can easily identify there is a position also exactly. So there's no doubt diagnostic confirmation of MRI is by diagnostic confirmation of AVN is by MRI. No doubt about that. Pathological changes in caisson disease. Very easy. What is that? Now you should be telling me physiology of the decompression sickness.
N2, sir. Option 1.
Very good. Very good. So when in deep waters, the gases are dissolved in the blood. Their gases are dissolved. Suddenly, if you come to the surface where the pressure, the atmospheric pressure comes reduced, the liquid dissolved gases will be suddenly released into the bloodstream. So there can be lung injury or there can be AVN also. There can be variety of problems, sudden decompression, or suddenly if you bring a diver above to the surface, all the gases. You remember in high pressure, the gases are in liquid state. Similarly, like that, what you seen liquid petroleum gas in the cylinder, what you use at home, the gas in under very high pressure is a liquid. Similarly, there is a liquid nitrogen which we use in the hospital. They are tremendously under pressure, that becomes liquid. But if you release the pressure, suddenly the liquid becomes gas. Similarly, the nitrous, nitrous which is there in the air, whatever you are breathing. Scuba is long form is self-contained underwater breathing apparatus. Okay, so that is not 100% oxygen. You have to have some amount of other air elements, natural air, because 100% oxygen is toxicity. You can go and read decompression sickness, but please remember, Caisson's disease is also one of the cause for avascular necrosis of the femoral head. Okay, one diagram just to avoid the monotony. What are the causes of the avascular necrosis is fracture, alcoholism. You please remember, somebody asked me about the question, excessive steroid use, polytrauma, thrombosis is sickle cell anemia, thalassemia, all thrombotic disorders. Hypertension, well, very rare, very rare. Okay, in a nutshell, I want to tell you about the AVN before we wind up AVN. AVN classification, you please remember if you can, Ficat and Arlett. Ficat and Arlett classification. If you can remember, it will be good. Ficat, Arlett, don't try to remember any degrees, how many types are there and other things. Just remember Ficat and Arlett. What you remember is, if you detect the AVN early, if you detect detect AVN early, if you detect the AVN late. So if you detect early, you can save the head. You can save the head. Means you do something so that the head will become viable. But if you detect late, you have to replace it. You have only treatment option is replacement. That is total hip arthroplasty or total hip replacement. Okay. So these are the early, there are salvage procedures. Early, there are salvage process. Salvage means what? You want to save the native head. Late means you want to replace. So salvage I had explained you earlier. There can be muscle pedicle graft. There can be vascularized fibular graft. There can be stem cell therapy, or there can be simple drilling hole of the femoral head. Okay, very simple. Okay, now I want to go to uh, osteochondritis. Osteochondritis is very interesting. I'll come to this slide again once again in the end, but I want to start this. See, avascular necrosis of different bones in the body are named differently. Okay, but there is a very good mnemonic for this, which I found. कलकत्ता वाली सुंदर रेडियोलॉजिस्ट फातिमा मलिक ओटी से चल के निकली पहुंची फिर पन्ना कॉलेज की लाइब्रेरी. I don't know whether you can remember, but you please, this is very important. If you want, you can make a note, or you might be able to search it, or you will find it. Better you make a note. Once if you write, it can save you from reading 10 times. कलकत्ता वाली सुंदर रेडियोलॉजिस्ट बाय नेम फातिमा मालिक ओटी से चल के निकली पहुंची फिर पन्ना कॉलेज की लाइब्रेरी. Okay, I will explain you here, then again I'll come back to this slide after showing you some interesting x-rays. Calcutta Wali. So CAV, vertebral bodies. Calcutta calves disease, vertebral body. Similarly, Sundar radiologist. Scheuermann's disease, where it affects ring epiphysis. Okay, at least few you will remember, then you can with little scratching of more head you will remember more. Fatima Malik, Freiberg disease in metatarsal head. Freiberg disease, M for metatarsal head. Similarly, Osgood, O for Osgood, T for tibial tubercle. OT से चल, SE is Severs, चल is calcaneum. कर निकली, Kohler's navicular bone. पहुंची, Perthes, P for Perthes, F for femoral head. पन्ना, Panner's capitulum. Keinbock's library, L is for lunate bone. I will show you this slide once again, but before that I will show you some interesting x-rays. This was one more diagram. It is a little complicated. Will not go there. Okay. Osteochondritis of which bone is Kohler's disease? Yeah. If somebody can recollect from the mnemonic, you will be able to say. Otherwise, if you have already read, you will be able to answer this.
Navicular.
Anybody?
Navicular bone.
Navicular bone. Kohler is navicular bone. Look at this diagram. See the navicular bone here. This is a navicular bone on the normal side. So what has happened? It is large. Compare the texture to the adjacent bones. They are same. Look at this. Compare the texture of the navicular bone with other bones. It is sclerotic. Always remember, avascular bone is more sclerotic. You might be surprised, but you should know this. Avascular bone is more radiodense. It appears very dense on X-ray because there is no resorption, there is no vascularity. Whatever bone, see in normal bone, there is always resorption and deposition. Okay, for this we have to have a good blood supply. But there is no blood supply means the resorption doesn't happen. Whatever bone remained will be always there. Here, because the resorption and deposition is normal, here there is no resorption. Any avascular bone always appear radiodense. You always remember this. The image X-rays, the image MCQs, there can appear such MCQs in future. So you see, comparative X-ray has been given. Navicular bone. This is a talus. This is navicular bone. Talo-navicular joint. Look at this navicular bone. It is small in size. It is more radiodense. So there is avascular necrosis of navicular bone. That is called as Kohler's disease. Keinbock's osteonecrosis. What is true? Read carefully. Apparently little difficult, but at least major wrong things you can easily rule out. Take a chance.
The third.
Yes, there is no doubt about this. Okay, osteochondritis of lunate is called as Keinbock's disease. Good. I wanted to show you a picture here. So you know the order of bones: S, L, T. There is a P here. T, T, C, H. She looks too pretty. Try to catch her. Okay. So look at the lunate bone here. Look at the other bones. They appear all normal. This is collapsed. There is a small radiodense fragment inside. This is classical X-ray of Keinbock's disease. I wanted to explain you one more thing here. There's some word which we came across associated with positive ulnar variance. I'll show you this diagram here, so you will remember. See here what happens. The distance between the articular surface of the ulna and the articular surface of the radius. This is called as ulnar variance. This can be asked in one of your future exams. Ulnar variance. If ulnar head is little more protruded, it is a positive variance. If ulnar head is behind or below the radial surface, it is negative variance. Understand? One thing you know very well, your ulnar styloid process is always ½ inch smaller or more proximal, ½ inch. You know why this is important? Especially in case of Kohler's fracture. Kohler's fracture, it is important. So whenever you examine a patient which is malunited, you will know that is important. So you please understand there is a difference between ulnar variance and the length of the ulnar styloid and radial styloid. Just a deviation, but I wanted to explain the positive and negative ulnar variance. Haglund's deformity is seen in which joint? Easy question.
Ankle joint.
Very good. Excellent. There's nothing much to explain. I have a diagram for that. We'll go to that. See, this is the calcification, or there is a bumpy swelling behind the heel. There is a fragmentation of the calcaneal tuberosity. This is called as Haglund's disease. Will not go into the treatment. I wanted to focus more of image-based MCQs today. Scheuermann's disease occurs in, very easy question. There is nothing much. You know, Scheuermann's happens in spine, isn't it? Tell me, quick. Option?
B. Second.
No, adolescent.
Third, sir. Third.
Third. See, our vertebral epiphyses are still not fused. See, whatever osteochondritis I am describing, they are before the fusion of the epiphyses. All these osteochondritis, what we are discussing today, happen before the fusion. So that means invariably they happen in adolescent. That is before the growth stops, before the maturity of the skeleton. Very simple. Okay, this is what I wanted to explain you. See here there is a ringed physis for all the vertebra, which will become end vertebra. So there is a osteochondritis. You can see there is a density here, the end of the bones. Ring epiphysis of the vertebra is affected. That is Scheuermann's disease. And this is one of the cause for adolescent kyphosis. Kyphosis you see in elderly because of multiple wedge compression fracture. But if you are seeing in a adolescent, the stooping of the posture of the adolescent, Scheuermann's disease can be one of the diagnosis. Sever's disease involves. I think you can take a chance here.
So second,
Huh?
calcaneum.
Very good, very good. See, lunate, you know, Keinbock's, tubercle, I told you. Osgood Schlatter's disease. Navicular, we know it is Kohler's. So what is remaining is Sever's. So this is one X-ray you will remember. You will never forget this. So always you see if there is a radiodense physis, if there is a radiodense epiphysis, you should suspect it is osteochondritis. Okay, if there is radiodense or if it is fragmented, and you can name it depending upon the site it is affected. So calcaneal calcaneal epiphysis is going for avascular Sever's disease. Always you remember, you should not get confused for Haglund's disease. Haglund's disease is in adults, post maturity. Okay, there is a swelling here. In Sever's, it is calcaneal epiphysis. Am I clear?
Yes, sir.
Osteonecrosis is not seen in. Very interesting question. I want somebody to answer this. Read carefully, you will not miss this.
Let's see.
Louder.
Olier's disease.
Anybody?
Olier's disease.
Huh? Anybody wants to answer, differ, agree? Okay, please remember, now we have almost seen everything. Keinbock's is lunate, Kohler's is navicular, Perthes is femoral head. So what is remaining is Olier's. Olier's you will never forget if you see this diagram. Look at this diagram. Olier's disease, Olier's is multiple enchondromatosis. Look at this. There's so many swelling everywhere. The pelvis is affected, tibia is affected, femur is affected, bilateral femur. See, so many swellings are there. in the child. It is cause for dwarfism. There's something called as Maffucci syndrome. Don't get confused. It is very easy to remember, but please remember Olliers disease is the answer in this question. Very tricky question, likely to be repeated in your future exams. Osgood Schlatter's disease affects, no brainer. Quick.
One.
Anybody else?
First one, sir.
Yes. And no doubt about that. Tibial tuberosity involves knee joint, isn't it? This I wanted to show you. Most people in very common, very common in adolescent young athletes. Very common. It is bilateral also. They come with pain in kneeling. They come with a swelling here below the patella. This is a patella. This is the your tibial tuberosity, which is abnormally swollen. It can be tender. Look at this. Look at this. It is fragmented. Osgood Schlatter's disease. Bilateral tender knee joint tibial tuberosity affected. Treatment is simple. All these treatments are very simple. Initial stage, bed rest and analgesic. Freiberg's osteochondritis. Very interesting choices. Very nicely arranged distractors. You should be able to answer this.
So it's metatarsal.
All are metatarsal, boss.
Metatarsal head.
Metatarsal
Head.
head. Okay, you have won half the war now. So it is second or fifth. So you have ruled out 50-50. You have ruled out. That's excellent. Now you are stuck, whether it is fifth or whether it is second. Take a chance. It is second metatarsal. It is second metatarsal head. At least you should know head, then you will know second metatarsal, because the examiner has said very nice. He has given second metatarsal base also. But I'll show you this diagram. You will never forget this. Why it is second metatarsal is, generally remember, even in hand or feet, the second is little longer. So whatever weight, if you observe yourself, today you go and observe how you walk. Once you strike the heel, the weight gets transferred medial side and then goes across the arch. Here your second metatarsal head is little longer. It takes 80% of the head is on the ball of the toe. 20% is on the four toes. Of this, the second metatarsal takes more weight. So Freiberg is osteochondritis of head of second metatarsal bone. Okay, am I clear? Just picturize this, you will never forget. Freiberg is osteochondritis of metatarsal head of second metatarsal head. Which joint is commonly involved in osteochondritis dissecans? Osteochondritis dissecans. Okay. Okay. You might find it difficult, but let me answer you this question. It is knee joint. It is knee joint. I'll show you a diagram. You will never forget this. See, osteochondritis dissecans means, remember, there is a patella here. There's always confusion because these choices are so confusing. I want to explain you, then only will never forget. This is a patella. Feel the patella wherever you are sitting now. Bend your knee. It gets tight on the medial side. Your patella, when you bend the knee, the see, if it goes laterally, it is a dislocation of patella. So naturally in every knee, it gets compressed for the medial condyle. And see this. You remember the lateral surface of a medial condyle is the most common site of OCD. OCD, osteochondritis dissecans. Dissecans means it gets dry. Dissecans is different. Dissecans is it gets dislodged. Dissecans is gets dehydrated. Now we'll come to this question. So most common site for this question was most common site for osteochondritis dissecans is knee joint. Most common site for osteochondritis dissecans is in the knee. Which part? Remember this diagram, then you will answer this question.
First one, sir.
Very good. Lateral part of medial femoral condyle. Just feel the knee, do that small exercise, you will never forget this. This is little tricky, but imagine you are yourself bending the knee, look for the patella where it gets tight, the lateral part of the medial femoral condyle, it gets compressed, that is the site you will see osteochondritis dissecans. That's how you will remember. Remembering, I told you, either repeated reading, memorizing, mnemonics, or visualization. Okay. So before I wind up, you want to note down the mnemonic for all this osteochondritis? I'll go back to the slide. Anybody?
Yes, sir.
Yes, sir.
That mnemonic I found was very, very interesting. That's why. Of course, you can form your own. Why do you waste time? Okay? कलकत्ता वाली सुंदर रेडियोलॉजिस्ट फातिमा मलिक ओटी से चल के निकली, पहुंची फिर पन्ना कॉलेज की लाइब्रेरी. Very, very interesting. You will never forget this if you can write this. Of course, it will be there in the video which we will upload, but you want to note it down, that's good. Otherwise, you can watch the video later on, right? So that's all for today. I have. Thank you guys. So though the topic was little short, but I find lot of image-based questions can be asked from these topics. Do you agree?
Yes, sir.
Yes, sir.
Okay. Yeah. Any